many attendees. And first of all, I will start by introducing Professor Magdi Salim, who is MD and PhD, Professor of Neurology at Harvard Medical School. And he is also the Chief of the Division of Stroke and Cerebrovascular Disease, the Director of Comprehensive Stroke Center at Beit Israel Deaconess Medical Center in Boston. He is fellow in the American Neurological Association, the American Heart Association, American Stroke Association Stroke Council, and the European Stroke Organization. Dr. Salim is known for his interest in the research into cerebral hemorrhage. He is the principal investigator of the two NANDS-funded clinical trials, the phase 2 intracerebral hemorrhage deferoxamine trial and the ongoing phase 3 statins used intracerebral hemorrhage patients. Professor Salim published more than 200 peer-reviewed papers and led the effort to establish the Hemorrhagic Stroke Academy Industry HEADS Roundtable, a think tank group comprised of leading researchers and physicians in the field, industry representatives, and decision-makers from regulatory agencies such NANDS and FDA, aiming to improve intracerebral hemorrhage research and develop a roadmap to expedite the development of new therapies. So Professor Magdi Salim will talk about stroke recovery, prognosis, and management. Thank you, Professor Magdi Salim. It's up to you.
Can you see my slides?
Yes.
Okay. Okay. Thank you very much for the kind introduction, Dr. Kisani, and I want to thank the organizing committee, Dr. Shahidi and Dr. Montano, and yourself for the invitation to be part of this webinar. So I was asked to talk about the current treatment for stroke, and obviously this is a big topic, and there are different stages to treating stroke. So I'm going to focus on acute stroke management, mostly really the first phase or the hyperacute phase. And just a brief introduction of what we're trying to do when we see a patient with an acute stroke. The first target or the first aim really is to maintain or keep the ischemic penumbra. What do I mean by this? When you see a stroke patient, there's always a part of the brain that's completely infarcted, which is depicted in black here. And then there is intermixed brain tissue where there is compromised blood flow, but it's not completely infarcted. It just leads to disturbance of function. And if we're able to provide blood supply to this tissue and save it, then we're able to decrease the amount of deficit and hopefully improve outcome. If we're not successful, then the penumbral tissue gets recruited into the infarcted area, and it leads to a bigger stroke and, of course, worse outcome. There is a lot of evidence to show that revascularization is correlated with good outcome. And as you can see here, that if you're able to achieve successful revascularization, there is improvement in functional outcome and independence. It's also associated with decreased mortality. It comes with a small rise of increased risk of symptomatic hemorrhage. But as you can see here, that the risk is not that significant. So overall, it's beneficial to achieve revascularization if we can. So there are really three principles that we try to achieve when we see an acute stroke patient and for acute stroke management. The first one is to achieve recanalization of the blocked blood vessel and reperfuse the ischemic tissue. So what do I mean by that? Recanalization means that we want to reopen the occluded artery. Reperfusion means that we want to restore blood flow to this hyperperfused penumbral tissue. And the extent by which we're able to achieve recanalization and reperfusion will determine the final size of the infarct and the severity of the deficits, and therefore the overall outcome. The second goal is to optimize the collateral flow. Collateral flow is really the flow that's responsible to keep the penumbral tissue viable so that we can save it if we achieve reperfusion. And we usually do this by just simple medical measures. We avoid dropping the blood pressure. Sometimes we try to raise the blood pressure, and by giving fluids. And then the third aim or goal is to avoid the secondary injury and reperfusion injury after you open the blood vessel. I'm hoping that maybe Dr. Jacobs in his talk will address some of the problems with the secondary injury and how it relates to recovery of outcome. But so far, we really don't have an established treatment to achieve the third goal yet. There are a lot of investigations going on in this area and some promising studies. Hopefully one of them will be successful. So how do we achieve reperfusion or recanalization? There are three ways to do this. One of them is just the simple medical management that we do for our patients by controlling blood pressure, but by avoiding high blood sugar, by avoiding hyperthermia or fever, and by using antithrombotic drugs. So I'm not really going to talk about any of these because that's a completely different topic. But what I wanted to focus on is what we do in the acute phase. And this would be either intravenous thrombolysis or endovascular clot retraction or removal. So stroke care has evolved significantly over the last few years. Up until 6 or 7 years ago, everything was driven by time. And everyone, of course, is aware of the statement, time is brain. And the table on top here shows you exactly why time is important. This is really a very nice paper by Jeff Saver from UCLA, which estimates the amount of neurons and synapses that are lost after middle cerebral artery occlusion. And what you can see here is that after 1 second, 32,000 neurons and 230 million synapses are lost. And it's estimated that after 1 second, the brain is almost 9 hours older than it was before. As you can see from the numbers, they go up significantly after 1 minute and up to 120 million neurons and 830 billion synapses after 1 hour. So there is no question that time is important when you're dealing with the brain. But what we have learned is that time is not the only thing. And there are two other important components that we look at, or maybe even three. I'll tell you the third one in a second. One of them is the tissue status. And what you see here, this is a perfusion scan. What you can see in purple, this is the area of the brain that's completely infarcted. Unfortunately, we can't do anything to reverse this. But then there's the green area, which is the penumbral tissue, and that's what we're trying to save. So in treating our stroke patients, we really need to have a better understanding of how big is this infarcted area, how big is the green area, the penumbral tissue, is there anything to save? Another factor that's not included in our paradigm yet, but hopefully soon will be incorporated, is actually location. Where is the infarct exactly? And then the status of the blood vessels, particularly the large vessels. Are they open? Are they blocked? So the decision-making will have to take into account all these three elements or four elements together. The time, the tissue, status, the status of the blood vessel, and perhaps the location of where the stroke is. So when we talk about intravenous thrombolysis, I'm going to talk about two drugs. The recombinant tissue plasminogen activator, or TPA, you're all familiar with, and tenecteplase. These are essentially similar. Tenecteplase is just a genetically engineered version of TPA. They work the same way by enhancing fibrinolysis and thrombolysis. And they work on the plasminogen that's bound to the fibrin. Within the thrombus, they activate plasminogen to produce plasmin, and then they create the fibrin and help dissolve the clot. However, there are differences between the two, which, as you will see later on, become important. So one of them is that TPA is usually inactivated by plasminogen activator inhibitor enzyme called PI1. This is not the case with tenecteplase. The specificity and ability to bind to the fibrin is much higher with tenecteplase than with TPA. And the plasma half-life is very different. It's much shorter with TPA than with tenecteplase. And as a result, the way we administer these drugs are different. TPA, many of you may be familiar. You give a bolus over 1 minute, and then you give an infusion after over 1 hour. For tenecteplase, it's only one bolus over 10 seconds, and you're done. So there are some logistical and practical advantages to tenecteplase over TPA, particularly the ease of administration, as you can see. Now, everyone is familiar with a big list of inclusion-exclusion criteria for intravenous TPA and intravenous thrombolysis. But the truth is, with the advancement in imaging in stroke, with our ability to use advanced imaging techniques, a lot of these criteria that led to excluding patients from treatment with TPA are becoming relative exclusion criteria. So a lot of them may not apply. So what I put here is what I think are really the major kind of eligibility criteria that you need to think about when you see someone with an acute stroke and whether they would benefit from thrombolysis or not. Of course, you want clinical signs and symptoms that suggest stroke. Time still plays an important role for the decision for intravenous thrombolysis, so up to 4.5 hours, although this is changing, as you will see in a few minutes. Measurable and disabling deficits. You don't want to give TPA or thrombolysis to everyone. There have to be some sort of deficit, and they should be disabling. There should be no hemorrhage on the CAT scan. You don't want a huge visible infarct on the CAT scan because the risk of bleeding becomes higher. No major surgery in the past 14 days. I left it there, even though this is also becoming sort of relative to some extent. It depends on the kind of the surgery. No ischemic stroke or head trauma in the past 3 months. Again, it depends on what kind of stroke they had before. And if it's a small lacunar infarct, maybe it's not an absolute contraindication. Low platelet count, high INR, and if they're taking any of the DOACs, except if you're in a place where you actually have the ability to check the level for the DOACs quickly and to make a decision whether you can treat the patients or not. So the point I'm trying to make here is that the eligibility for TPA has been modified significantly, that now you can treat a lot more patients than we were able to treat a few years ago. Now for the 3 to the 4.5 hour window, there are additional eligibility criteria, and this is based on the trial that looked into this. Again, age younger than 80, although age is becoming very relative these days. It really depends on how functional the person is. No concurrent use of anticoagulation, regardless of INR. NIH, actually the guts type should be greater than 25. And if the patient has history of diabetes and stroke. So you can see here, this is a meta-analysis looking at the benefit of intravenous TPA at different time points. And as you can see that overall it's beneficial, particularly if you give it within 3 hours. As you can see here, the odds ratio for favorable outcome drops when you move on to the 4.5 hour window. An important thing we have learned over the years is that TPA is helpful regardless of age. You can't really exclude patients just based on their age. So helpful if you're younger than 80, helpful if you're older than 80. And it's helpful in most cases, regardless really of the severity of the deficit. This is an important point here, and I'm going to show you in a second one. This is a trial called the Prisms trial, and it looked at the use of TPA in people with mild strokes, patients in whom the NIH stroke scale is less than 5. And the reason for this is that initially TPA was contraindicated in patients with mild deficits because the natural history is that they tend to improve on their own. And of course, there was a desire and kind of an important research question to look at whether we can expand the pool of patients that we can treat. So this trial was stopped prematurely because of poor enrollment. However, what you see here, this is the outcome of patients treated with TPA versus no TPA, and basically there was no difference. There was slight increase in the risk of hemorrhage when you give people TPA, but that's expected because you're comparing it to placebo. So based on this trial, really kind of the general thought now is that if someone has mild deficits or low NIH stroke scale, it depends on the nature of the deficit to decide whether you want to treat them or not. If these are disabling deficits, you probably should consider it. But if they're just a little bit of numbness, tingling, a little bit of a facial droop, then probably not, because as we can see, there is a slight risk without an added benefit. This is sort of a little bit of a subjective criteria because disabling deficit will vary from one individual to another. So, for example, if a dentist or a surgeon, any little problem with their hand could be quite disabling. A person who's retired and doesn't work, maybe that's not a very disabling problem, and we can wait and see what will happen to them if they will recover or not. A taxi driver, for example, a little bit of a field cut might be quite disabling. Again, someone who does not drive, maybe an upper quadrant anovia or a field cut is not quite disabling. And maybe you want to see what will happen with time instead of taking the risk with TPA. This slide here to show you what I hope most of you know is that the benefit of TPA declines over time. So the more time it is from stroke onset, the lesser the benefit and the higher the risk. So the greatest benefit you would get is if you're able to treat within 90 minutes. Very high benefit, as you can see here. You need to treat 100 patients, 27 of them will become completely independent, and the risk of mortality or death is very low, only one patient. As the time moves on, you can see the red is going up and the green bar is going down. I like to look at this in number needed to treat to benefit and the number needed to treat to harm, because I think it's an easy way to actually present it to the patients. And what you can see here is that within the 0 to 90 minutes, you need to treat only 3.5 patients, basically, for one of them to benefit. And as the time moves on, you can see that the number goes up. Here is the number needed to harm. And as you can see, if you're treating within the 0 to the 90 minutes, you can only harm one if you treat 65 patients. But as time moves on and you're in the later treatment window, only 14 patients and you can harm one. So time is really important, as I mentioned, as a parameter in this case. So again, with the changes in how we image the patients and how we approach the patients and the thinking that not everything is just time-based, you have to take into account the tissue and the vascular lesion. This is actually also starting to change the way we think about thrombolysis. So this is the Extend trial. And what they did is that they looked actually at treating patients up to 9 hours, between 4.5 hours to 9 hours, and based on imaging criteria. So based on perfusion imaging, if you see a small infarct and a large tissue at risk, then you can go ahead and treat the patients. And what they found out is right here, is that actually if you use this approach, TPA is beneficial in improving outcome up to 9 hours from treatment. So you can see here, 35% of the patients treated with TPA were independent compared to 29% with the placebo. The only problem that happened with this is what we expect here. When we look at the symptomatic hemorrhage, there was some increase with treatment in the late time window. But again, the benefit might outweigh the risk. It depends on the severity of the presenting symptoms. This is a meta-analysis that pulled the data from this Extend trial that I just presented and 2 other studies called Epithet and Diffuse, which also used advanced imaging. And basically, they found the same results. You can actually use TPA beyond the 4.5 hours if you're using perfusion imaging, and if the patient have actually small core, large penumbra, and as you can see that there's improvement in functional outcome, modified ranking 0 to 1, but again, there's a slight increase in the risk of hemorrhagic transformation as well. So it's 5% compared to 1%. So what do you need to actually use TPA in the extended time window? Unfortunately, you need to have perfusion imaging, penumbral imaging. So this is not something that you can use just using a plain CAT scan. You need to be able to do either perfusion MRI or perfusion CT scan. In this extent trial that I just mentioned, they only enroll patients that do not have large vessel occlusion. So that's ideal for that. It's also a good treatment if you have someone that had a vascular occlusion, but it's very distal that we can't get to it with our devices. So that's a consideration to use there. And there are some people that are thinking, well, that could be a nice bridge. Let's say a patient comes in the middle of the night, your interventional team is not available in the hospital. It takes them an hour to come in. You're just going to sit and wait for an hour, or should you go ahead and treat them? The trial didn't look into that, but we have done this at our institution a couple of times, and so far we did not really have an issue with it. So that's, again, something to consider in these situations when your team is not available and the waiting for thrombectomy will be long. This is another trial to also support that you can use TPA in the extended time window. This is called the Wakeup Trial. And it's mostly looked at patients who wake up with a stroke, and it's not really clear when the time of onset was. And they used an imaging technique called diffusion flare mismatch. And you can see an example here on top. So here is a patient on the diffusion weighted imaging. You can see that there is an abnormality. On the flare imaging, you don't see any abnormality. So there is a mismatch between the flare and the diffusion imaging. And what this tells you is that the stroke actually is recent. It happened within just a few hours, because it takes few hours to see the flare imaging. And so they went ahead and selected these patients who have the mismatch and treated them with intravenous TPA. And again, you get the same results. There was improvement in functional outcome with treatment. There was also a slight increase in the risk of hemorrhage, but it was not significant in these trials. So again, I guess I'm trying to make the point that with the use of advanced imaging and adding tissue to time, you're able to extend the time window for treating these patients. Now, what about tenecteplase? So there is evidence that's slowly building up that tenecteplase is at least as good as TPA, and it's not inferior to TPA. We don't have evidence yet to say it's better than TPA, but we have evidence to suggest that it's as good as TPA. So this is a meta-analysis that looked at 5 studies that evaluated tenecteplase, and some of them are big, some of them are small. We use different doses, but overall, this is the inferiority margin here. And this is looking at modified ranking 0 to 1 after 3 months. And what you see here is that actually tenecteplase crosses the inferiority margin. So it's not inferior to TPA in these situations. This is a different way of looking at it using modified ranking 0 to 2. Still, the patient is independent, but not as good as 0 to 1. And again, you can see that the tenecteplase is not inferior to TPA. So the American Heart Association guidelines, in the last guidelines that came out last year, actually suggest that it is not reasonable to treat with tenecteplase instead of TPA. And this slowly is kind of gaining popularity for a couple of reasons. Number one, in certain parts and in certain countries, it is much cheaper than TPA. So that's, of course, appealing. It is easier to administer. As I said, it's only you're giving 1 bolus over 10 seconds and you're done. And this has an advantage if you're trying to move one patient from the hospital to another hospital and you want to get them in an ambulance. You don't need a bump to continue the infusion. It's faster to deliver the drug. And especially during the COVID-19 period, we're really at its peak here in the United States, a lot of the places started switching to use tenecteplase instead of TPA. But what's the problem with TPA or intravenous thrombolysis in general? The problem is that, of course, the ability to dissolve a clot depends on the burden of the clot, how big it is. And as you can see here, the ability to achieve recanalization with intravenous TPA is only 40%. And as the clot gets bigger, then the effect of TPA becomes less pronounced. So it turns out that we have 20 or 30% of ischemic strokes are related to large vessel occlusion. And of course, a large vessel occlusion means that it's a large clot that's blocking it. And TPA may not provide the maximum benefit in these patients. 20 to 30% ischemic strokes, that really worldwide add to almost 3.4 million people who can benefit from a treatment stronger than TPA. So we'll go back to tenecteplase again. This is called Extend IA trial. So it's an interesting trial that was done in Australia. And it's basically compared intravenous TPA and tenecteplase. So they give it within 4.5-hour window in patients with large vessel occlusion. And their endpoint was not who will do better. The endpoint were when now we're taking this patient to the angio suite and we do an angiogram, which one of them is better in actually either achieving recanalization, opening the blood vessel by at least 50%, or actually you take them to the angiogram and the clot is gone and you don't need to do anything anymore. And when you look at it this way, actually tenecteplase was much better than TPA. So a lot more patients that received tenecteplase, when they took them to the angiogram, the blood vessel was at least 50% open, or they just didn't need the procedure to start with because the blood vessel was completely open. And not surprisingly, this translated into improved functional outcome at 90 days in the study. The only problem with the study is that it's a small number of patients. It's only 100 patients. It's certainly promising, but small. So how can we identify that someone has a large vessel occlusion? Not everyone had the luxury of having a stroke mobile. I don't know, there are many places in Europe and in Canada and in the US now that have a stroke mobile. So for those of you who are not familiar with, this is an ambulance that just deals with stroke patients basically. And inside the ambulance, there is a mobile CAT scan. So you pick the patient in, you put them in the scanner, you get the CAT scan in the ambulance, and you know immediately what they have. They have a stroke, they have a hemorrhage, they have a blocked blood vessel. So you're quickly able to determine if they have a large vessel occlusion or not. But I think most of us don't have the stroke mobile. So how can we identify this? So aside from imaging, people have used different scales that may increase the likelihood that what you're dealing with is a large vessel occlusion. So there are many of them that we use here in the United States. One is called Cincinnati, and that's because it was developed in Cincinnati, a city in the United States. The other one is called RACE. The third one is called FAST-ED. And I'm just showing you here example, and all of them really rely on just quick assessment by the ambulance people and the emergency response team. Do they have facial droop? Do they have eye deviation? Do they have slurred speech? Do they have arm weakness? And then you add the points. And of course, the higher the score, the higher the likelihood that this is a large vessel occlusion. None of these scales is perfect. As you can see here, the sensitivity and specificity for them, I have it for all of them, and it varies from the 50s to the 60s and specificities up to the 80s. It's in Boston, where I live, we use FAST-ED because if you compare those three scales that I presented, it seems to be the one that highest predictive capability compared to RACE and Cincinnati. But again, as I said, none of them is really perfect, but if you don't have anything, I think these are better than nothing, and it will help you early on to determine whether this is a high likelihood of having large vessel occlusion or not. So why is this important? because we know that thrombectomy now is widely used and it's very effective. You can actually achieve recanalization. You can open the blood vessel in up to 88% of the patients when you do it. And up until 6 years ago, stroke were really completely dependent on intravenous TPA. But thanks to many of these trials that were completed in the 2015 and 2016, the language we use now for our stroke has completely changed. We talk about something called Tiki Score, which gives you an idea of how open the blood vessel is. We talk about M1 and M2, which is which part of the middle cerebral artery is occluded. Is it the proximal part, M1, or is it the distal part, M2? We talk a lot about something called the aspects score, which I'm going to explain in a few minutes. But the field has completely changed with the introduction of thrombectomy and the results of these trials. So this is now the new paradigm really for stroke. You get the stroke patients, you get a CAT scan, you determine that there is no hemorrhage, you consider them for thrombolysis, and then you look at their blood vessels, do they have a large vessel occlusion or not? And then you look at the perfusion imaging and you see if they have small core and a large number. And these are the numbers that we use here to determine whether someone would qualify or not. And of course, we don't sit there and measure them thanks to automated software. Now you get this stuff immediately coming out of the CAT scan machine within seconds. And if the patient meets criteria, they get an angiogram, you open the blood vessel, and then you get another angiogram after this, and you can see the result of your work. And in places that are fortunate enough to have the stroke mobile, maybe they would even bypass this first step because it's done very quickly, and even some places are able to administer TPA in the ambulance. So these are the thrombectomy trials that were completed in 2015 and 2016. I just kind of summarized them here, but I'm going to highlight the main points. Is that in all of these trials, the time to randomization from stroke onset within 6 hours, only one trial was 12 hours, but that was very few patients. And that most of these patients were treated with TPA first, and then they went on to thrombectomy after that. So you can see here, this is the percentage of patients that received TPA in the thrombectomy arm, and in the other arm, the medical arm, whether it was TPA or just medical treatment alone. What's really important here is the time from stroke onset to reperfusion, their ability to open the blood vessel. And as you can see, that the longest was 355 minutes. So they were efficient and able to do things quickly. So now these are the results of this trial, and this is looking at modified ranking 0 to 2 at 3 months. So basically patients who are independent after 3 months. And as you can see, green is mechanical thrombectomy, control means TPA or medical management. And you can see that the percentage of patients who achieved favorable outcome was higher in the thrombectomy arm compared to the medical arm in essentially all of these trials. So the odds ratio for having a favorable outcome with thrombectomy varied from 1.8 to 4.2. So a very, really robust effect. As I said, these trials were mostly up to 6 hours. After this, there was the Dawn trial, which extended the window to 24 hours. Again, using the same imaging technique, perfusion imaging. And I just want to highlight this, and I'm going to mention later why it's important really to rely on the imaging. And again, there was a benefit with treatment, even when you go all the way out to 24 hours in patients with large vessel occlusion who have a penumbral tissue. Another trial, Diffuse 3, replicated the same results up to 16 hours. So when all of these trials, the data were pulled together, you can see the results here. And you can see even when you look at different subgroups, thrombectomy was actually beneficial in improving outcome. How beneficial it is. So as you can see here, when you pull all of this data together, you can see that with thrombectomy, 46% of the patients that you treat after 3 months are independent. That's almost 1 in 2. So every other patient actually would benefit and would become independent, compared to only 1 in 4 if you're treating them with intravenous thrombolysis. So it's obviously a very strong and robust effect. So what is the harm from thrombectomy? What people usually are concerned about, either hemorrhage, and this is because you're putting a device in. As you move the stent, you can perforate a blood vessel, a reperfusion injury. During the procedure, some people might need to use anticoagulants. However, it turns out from these trials that actually the risk of hemorrhage was not significantly higher than TBA alone. So in experienced hands, the overall risk was 4%, 4.4 versus 4.3. So it's not that much different. What about new infarct? As you go in, you're playing around with a clot, you can break it, it can move distally, you can have a new infarct. Yes, this can happen, but the risk is not huge. It varied from 0% to 4% in these trials that I mentioned. So it doesn't mean because we can treat patients up to 24 hours that this first component that I mentioned, importance of time, is gone. Time actually is still important. And as you can see here from this figure on the right-hand side, is that the benefit of thrombectomy decreases with time. So the sooner you're able to do it, the better, of course. And the faster you're able to achieve reperfusion and recanalization, the better it is for our patients. This is just to give you an idea again. So what happened for every minute delay in achieving reperfusion, 1 in 100 patients will have worse outcome after 3 months. If you delay it by 5 more minutes, it doubles. It becomes 2 more patients. So again, it really highlights that the clock will always be driving how we treat stroke patients. But thankfully, we have ways to extend the time that we can treat the patients within, but the sooner the better. Because time is important, there have been interest lately in, can we just avoid this TBA and just take the patient directly to the angio suite? Of course, not everyone has the luxury of doing this, but if you happen to be a place that have the resources to do this, is it better to just take the patients directly when they come in to take them to the angio suite? So the trial have looked into this. This is the first trial that looked into this was in China. And it basically found that there is no difference. So if you give them TPA and then you take them to the angio suite, it's the same outcome as if you take them directly to the angio suite. And their conclusion was that going directly to the angio suite is not inferior to treating them with TPA first and then taking them to the angio suite. Several other trials have looked into this. These are 3 more trials, and basically all of them are the same. They found that going directly to the angio suite is not really inferior, although there is a debate out there how these trials defined non-inferiority. So some of them used up to 20% difference as the inferiority margin, which some would argue is big. But overall, it looks like the benefit is the same. The risk of hemorrhage is the same. So I think the approach here really depends on the institution and what you have. If it's going to take you 30, 40 minutes to get a patient to the angio suite and to start opening the blood vessel, then you should probably go ahead and start intravenous treatment first. If someone is seen at outside hospital where they don't have the resources to do thrombectomy and they have to send them to a bigger hospital, of course, it makes sense to start intravenous thrombolysis first. So I think no matter what, intravenous thrombolysis is here to stay, and there will always be a use for it, and thrombectomy will be an add-on, but it's an important add-on, of course. So how do we select the appropriate candidates? Who is actually appropriate for thrombectomy? So in the trials or in the initial AHA guidelines, they suggested that you need to have an NIH stroke scale greater than 6. I think in real life, things are a little bit different. And I'm one of the people that I think if there is a deficit that is disabling, even though your NIH stroke scale is not 6, it's probably justifiable to consider thrombectomy. Of course, you need to find large vessel occlusion on a CTA, and it's in a location where you can access it. And then we'll come to a second what kind of imaging you do. If it's less than 6 hours, people use something called aspects. And this is based on a plain CAT scan, and the score would have to be greater than 6. I'm going to explain it in a second. Or you can use the perfusion imaging if you have this capability. And then the patient needs to have a good pre-stroke functional outcome. In all of these trials, the patients that were enrolled were completely independent at baseline. They had to be less than 1, their pre-stroke modified rank. In real life, that's a little bit different. You get a lot of patients that maybe their modified ranking is 3. So maybe they're walking, using a cane, but they're happy with their life, and the family will always tell you this is one shot, either works or not, we're happy with that. So I think there is a little bit of subjective assessment there and discussion about what really is considered a good pre-stroke functional outcome and who you want to treat and who you don't want to treat. So what kind of imaging should we use? I want to go back to the slide when I showed you the results of the thrombectomy trial. And the one I highlighted here, Extend IA, and you see that this is the one, 71% of the treated patients achieved good outcome. This is higher than any other trial, as you can see. And if this was live, I would have asked the audience to actually guess or say why they think that's what it is, but it's not. And the reason for it is that this is the only trial where all the patients had perfusion MRI. So they used MRI for all of their patients. And it's probably the most sensitive imaging modality to actually carefully select these patients. So the selection of the patients was really very careful, and that's why we did very well. If you don't have the luxury to be able to do MRI acutely, and you don't have the ability to do perfusion imaging, what people use is something called the aspect score, Alberta Stroke Program Early CT Signs. So this is a poor man's version of trying to use the perfusion imaging, if you wish. So what happened is just a systematic way of looking at the CAT scan. You look at 10 areas of the brain, and you see them here. And every area, if it looks normal, you give it a score of 1. So if you get 10 points, that means that the brain is completely normal. You don't see anything. And if you see hyperdensity in any of this area, you subtract this point. And in the trials, patients with an aspect score 6 to 7 seem to benefit. Less than that, the general feeling was that they would not benefit because then it would be a large stroke. So people use this way, kind of use the aspect score as a way to kind of get an idea about the size of the infarct and whether they should be treated or not. So most of the trial that I showed you actually use the aspect score within the 6-hour window. So I think it's okay to use it. So the minimum imaging that you would need in anyone is really a plain CAT scan and the CTA, and use the aspect score to evaluate the CT. And you can do this after 6 hours. I personally think that there are some problems with the aspect score, but if you don't have the advanced techniques, that's all you can go with. And the problems is that if you compare it to infarct volume on MRI, it's not exactly the same. Of course, a CAT scan is not as sensitive. So if you have a little bit of periventricular white matter disease, atrophy, leukorrhiosis, it can fool you a little bit and you might overscore it. There is big variability between different people doing it and the scores that you get from different people. And actually the ability to see these changes clearly depends on the amount of radiation that people get for the CT. So the more the radiation, the better the quality, and it's easier to see it. But the less the radiation, the harder it gets. And so it's a balance between you want to give the patient more radiation to be able to see this better or not. So at our institution, because we have the ability to do perfusion imaging, anyone after 3 hours, we do perfusion imaging on them. Now, we talked a little bit about how to select the patients and who are the appropriate patients. But what happens in real life is a little bit different. So this is a study from Germany. And they looked at all the patients that they treated with thrombectomy, almost 260 patients. And they looked at the ones that actually matched all the guidelines, the AHA guidelines for who should be treated, and the ones that were just treated even though they did not meet the guidelines. Because in real life, people are treating a lot of patients that don't meet the criteria for those included in the trials. And what they found is what you expect, is that the outcome of those patients who don't meet the criteria is not as good as the outcome of patients who met criteria. So you have to be careful because, again, it's a procedure. You move a lot of people to come to do the procedure. There are a lot of resources involved. And if the outcome is not going to be as good, you have to be careful. The authors of this paper actually reached the wrong conclusions. So what they found is that, yes, the outcome is worse, but when they looked at the ability to open the blood vessel, it was the same rate of success, and the risk of hemorrhage was the same. So they said, so it's not really harmful. It's technically as successful. So we should treat more patients with thrombectomy. So it depends kind of if you want to see the glass half full or half empty, you can look at this data. So just briefly, even though we have lots of advances here that I just mentioned in the last few years, the outcome stroke patients is still not as good as we hope or as we wish. So this is a large study from Sweden looking at following up their patients up to 5 years, and a large number of patients, almost 23,000 patients, and looking at their outcome over time. And as you can see here, they looked at an intercerebral hemorrhage and ischemic stroke, but we'll focus on ischemic stroke here, that even after 5 years, almost half of the patients are dead, and a large number of them are disabled, and only 20% of them are independent. And when you can see here, when you start looking at it by age, it turns out that, of course, age and pre-stroke functional status are probably the most important determinant of how the patients will do. So this study was from 2019. And so most of the patients are actually were before the thrombectomy era. The question is, do we think thrombectomy is going to change these outcomes that we see? And there is some suggestion that it might. So this is a study looking at the cost effectiveness of thrombectomy and whether you're able to achieve recanalization within 6 hours, after 6 hours, or not at all. And this is using the numbers that we get from the trials, which again are different from real life. But if we are as successful as the trials are in improving outcomes, you can see that there is significant benefit because the number of patients going to rehab is less, the number of patients going home is better, the mortality is less, and even the expenses are less. So the take-home message here is that intravenous thrombolysis with TPA and thrombectomy are both established, and we have good evidence to support their use. Many of the original contraindications to IV TPA no longer exist or are becoming relative. Therefore, you can treat a lot more patients. Mechanical thrombectomy is helpful if there is contraindication to intravenous thrombolysis. Tenecteplase is on the rise, and I wouldn't be surprised that in a few years will become the major thrombolytic agent to be used. The time to reperfusion is important. So time is important, but tissue is also important, and careful assessment of imaging is particularly important when you get beyond the 3 and 4 hours. Stroke recovery looks like there is more that needs to be done, and I'm hoping that Dr. Jacobs will take it from there. So thank you very much.
So thank you very much, Professor Magdi Selim. It was really very interesting talk, and I think we will have a lot of questions. So I think we'll let the questions till the end after the second speaker, who is Professor Jack Jacobs. I will introduce him briefly. So Professor Jack Jacobs, he is the President and Chief Scientific Officer of Zetia Genesis Medicine Company in Las Vegas, Nevada. He received his bachelor degree from Davidson College, North Carolina, and molecular biology from Washington University in Missouri. He has been involved in the healthcare industry for over 25 years, and has extensive expertise in supervising drug manufacturing, operations, and the design and implementation of preclinical animal trials in the FDA authorized clinical trials. He started the new department of biological chemistry at the pharmaceutical company Merck for 15 years as the chief science officer of cardiovascular biotherapeutics, where he oversaw the FDA authorized clinical trials in which the angiogenesis drug candidates, human FGF1, was tested in a number of medical indications, including coronary artery disease, diabetic foot ulcers, and peripheral artery disease. He has been continuing the drug's development for this time with this mean. So Professor Jacobs will talk about stroke recovery, novel future therapies utilizing therapeutic angiogenesis. Professor Jake Jacobs, you are invited to start your presentation. Thank you.
Thank you, Professor Khassani, and thank you, Dr. Salim, for a very nice talk. I enjoyed listening to that. We're going to switch gears a bit. We're going to go from acute stroke to chronic stroke or stroke recovery. And we're going to stay mainly in preclinical work, show you some preclinical data, which is going to allow us to start our first human study in about 6 months. So we've gotten approval to go into stroke patients with stroke disabilities with this drug, this growth factor that we're developing. So what I'm going to do, I'm going to show you a little bit of data, human data that we have in the heart, because this medicine grows new blood vessels. That's what angiogenesis is, the growth of new blood vessels. It does that very well in the heart. We have done 4 separate clinical trials in the heart. So I'll just show you some data there and then move into data from stroke recovery animal models. And then finally, the design of our first clinical trial, which we started. Okay, as all of you know, stroke is a significant problem. It's actually decreased. Number of stroke deaths has decreased, perhaps due to better diets or lifestyle, but it's still a very significant problem. And as Dr. Salim mentioned, still quite a bit of disability and death following a stroke. This surprised me. There are over 75 human diseases that result from a lack of impaired blood flow to a tissue or an organ. We're actually working on over 10 of these, but obviously coronary artery disease, stroke come to mind, but we're also working on some neurodegenerative diseases, which we and others believe initiate by lack of blood flow to certain areas of the brain. I won't talk about it today, but we're really focused on developing a drug that stimulates new blood vessel growth in ischemic or damaged tissues. And just to show you, this is natural angiogenesis. We use it all the time. This is a wounded area. So cut or scrape, we look underneath that scab, and here's angiogenesis at work. There's new blood vessels perfusing this damaged area, and will regenerate skin as an organ, sweat glands, hair follicles, nerves, blood vessels. And the growth factor we're developing, which I'll talk about in a second, FGF1, is the most potent stimulator of angiogenesis, of new blood vessel growth in our bodies. And in fact, the growth factor we're working on can also generate small arterioles as well as these capillaries. So it really can reperfuse damaged tissues. And in the brain, that's coupled, as I'll show you, to neurogenesis in the brain in animals that have been given an experimental stroke. All right, here's the growth factor, FGF1, fibroblast growth factor. Amazingly, I worked on this 30 years ago as a graduate student in St. Louis. It's most abundant in our brains. We purified it from cow brains and did the structure, and then I worked on it a bit at Merck. For our clinical trials, we won't use cow brain FGF1. We make the growth factor in industry standard FDA inspected facilities. We grow it up in these incubators, fermenters full of bacteria that make the human protein. So it's a very industry standard technique to make drugs for clinical trials and commercial sale. And as a biochemist, I want to apologize, but I have to show you just one biochemist slide. These are our protein gels we use all the time. Just want to show you how powerful the recombinant DNA technology is. So when we grow up those bacteria and then crack them open, each one of these bands is a bacterial protein, all right? And the human protein, there's one. Here's human FGF1. So the bacteria is making this human protein as a dominant protein in its body, which is just remarkable. These are all toxic to people, so we've got to get rid of them. We purify the FGF1 so we get pure, potent human FGF1, which is suitable for clinical trials. So here is the process of angiogenesis. When we inject FGF1, or it's produced in our bodies after we cut ourselves, it binds to the FGF1 receptor on existing blood vessels. All right, so like a key going into a lock here. This stimulates the process of angiogenesis. We get endothelial cells activated, they begin dividing, and they form these small little tubes. And here we have brand new blood vessels, capillaries, growing into, in this case, the wounded area, bringing blood perfusion to this area. Same thing occurs in the heart, and the same thing can occur in the brain, and I'll show you data on that in a few minutes. Very important concept. So in ischemic areas of the heart and the brain, the receptor for FGF1 gets upregulated over time. So healthy tissue, there's not much of the FGF1 receptor. We inject FGF1 into healthy heart, into healthy brain, we get no blood vessels, new blood vessels form. Over time, as a tissue becomes ischemic disease, we get a tremendous upregulation of the FGF1 receptor. So the tissue is primed to react to FGF1. And so what therapeutic angiogenesis is, we introduce large amounts of FGF1 into the heart, into the brain to kick off angiogenesis in these stressed or ischemic tissues. And that gives us a very nice safety window. So if we inject FGF1 as we will intravenously, it really doesn't do anything to healthy tissues in the body, but only in those tissues where the FGF1 receptor has been upregulated, sometimes 100-fold. Okay, let me just show you, I'm just going to show you a short video. This is a clinical trial that I supervised. Two were done in Germany, one in the US that I supervised, where we introduced FGF1 directly into the hearts of patients with severe coronary artery disease. So these patients were too sick to have a bypass or stenting. They're called no option heart patients. And we actually did a little mini thoracotomy and injected the FGF1 directly into the heart muscle. Previous trials had tried to put it intravenously or into the coronary arteries, but you really need to inject the growth factor right into the heart muscle, where it stays there for about 3 to 4 days to kick off the process of angiogenesis. So I'm going to show you a news clip. ABC News went down to our Cincinnati site. That was our best site, highest enrollment there, and actually interviewed our cardiologist there and some of the patients. And I won't talk through this, but the cardiologist is going to point to the patient's heart where they were injected with the FGF1. And you can really see a nice new blush of new blood vessels growing that persisted for over 3 years, stayed patent for over 3 years. So let me run this news clip. I won't talk through it, but I'll be back at the end of it.
But since receiving an experimental treatment for his blocked arteries, his pain is gone.
I really feel great.
Duke was one of the first heart patients in the country to be treated with a protein actually capable of growing brand new arteries. The genetically engineered protein is injected directly into the heart. Within days, a network of new vessels begins to grow around the blockage, increasing the blood supply. Dr. Lynn Wagner showed us the changes in one patient's heart.
We see a small, narrow main artery and not very many secondary and tertiary arteries. This is after the treatment. What we're now seeing is new blood vessels growing here off the end of this artery.
And the patients themselves?
Symptomatically, they're improved within a couple of weeks of the treatment.
Just ask Constance Donnelly.
Oh, I feel wonderful. I've never felt so good in the last 5 years.
But doctors already see potential in other cases where the blood supply needs a boost, such as strokes and diabetes.
Okay, as he mentioned, strokes. So let's talk about its potential for chronic stroke patients. We're continuing that heart study. Actually, we now have a catheter, so we can have a femoral approach and inject from inside the heart ischemic areas. So we're giving patients 10 to 20 shots with a Johnson & Johnson catheter, and that is working out quite well. Okay, for chronic stroke, we're not into patients yet. I'm going to show you some preclinical data, which we think is very promising. Caveat is things that work in animal models of stroke don't always translate into humans, but you've got to do your preclinical work first, and we're now ready to start our first human trial. So, like in humans, this is a human, but we can give mice and rats experimental stroke simply by tying off a vessel for a period of time. Sometimes we leave it occluded permanently, sometimes we open it up for reperfusion, but the animals, just like in humans, develop an infarcted area in the brain, area of dead tissue, and then the pink is, as Dr. Salim talked about, the penumbra, so area at risk. I'm going to show you data. Again, we're going to treat animals where the stroke is more or less stabilized. It's not an acute stroke. And we're going to try to not only save area at risk, but try to repopulate, regenerate new neurons in infarcted areas as well. So here's a typical example. This is in a mouse given a stroke. The white area is infarcted. We then treat animals intravenously for 2 weeks. So this is after a day. The animals have pretty much calmed down after 24 hours. And then 2 weeks, every day, we give them IV infusions of the growth factor. And I think you can see what I believe is a remarkable difference in the damage between the treated animals and the untreated animals. So we see about a 57 decrease in volume in these animals. We can actually look in the brains of these animals and see if we're regenerating the vasculature. So this is normal capillaries in a mouse brain, okay? You don't see the neurons here, but they're there. And then we give those animals a stroke. 24 hours later, you can see basically the decimation in that infarcted area, destroying these blood vessels. The animals that got FGF1 are drugged intravenously for 14 days. We see regrowth in that area of a capillary. It's not quite back to normal, but you can see much better than the placebo-treated animals, where they're trying to regrow back their vasculature in the stroke area, but not doing a very good job. Kind of disordered blood vessel growth. These vessels are actually hemorrhaging, so the animals are doing much more poorly. And then we can put these animals on a rotating bar to kind of infer that we're regrowing neurons. So this bar is rotating. Normal mice can grab onto that bar. Here's the FGF1 treated animals. You know, not quite as good as these guys, but they're hanging on. But the placebo treated animals have fallen off the rotating bar and are nowhere to be seen. So from these types of experiments, we can infer that we can see we're growing new blood vessels. We can infer we're regenerating through neurogenesis new functional neurons. What we believe is happening is pools of stem cells in those animals obviously need proper blood perfusion to differentiate into all the cells in the brain that make up healthy brain tissue. And by revascularizing the brain, we're actually activating this population of neural stem cells. This is a different experiment. This is looking at infarct volumes in the cortical regions of the brain. So vehicle is in white, and I'm sorry, vehicle, these are the two vehicle treated, and here the two FGF1 treated groups. You can see a significant decrease after 28 days in the treated animals. We can look at neurogenesis in those animals. Here's in the olfactory nucleus, control treated, higher density of neurons. In the forebrain, again, a higher density of neurons in those treated animals for 24 days. This is the longest experiment we've done. This is in a rat that was treated for 9 weeks with FGF1 daily IV doses. And you can see a significant reduction in the infarcted area in that rat. So these types of results give us hope that, at least in animals, we can not only revascularize the brain, but also can repopulate the brain with functional neurons. So FGF is neuroprotective. It stimulates neurogenesis. It can stimulate new blood vessel growth, angiogenesis. It can increase regional cerebral blood perfusion. And importantly, we've shown that about 5% of an IV dose of FGF1 can penetrate and get into the blood-brain barrier. These in normal animals. It's possible that in an animal with a stroke, the blood-brain barrier is further degraded, and perhaps more FGF1 can get into the brain. But in normal animals with intact blood-brain barrier, there's a receptor-mediated transport mechanism that can get FGF1 into the brain. All right, so this is the clinical trial, which has been approved. We're going to look at 3 ascending doses of the FGF1. And we've done a lot of safety and toxicity testing in both rats and dogs that the FDA makes us do. So we're going to be using doses that have been shown to be safe in those animals. And we'll be studying patients who are at least 6 months post-stroke. So they're more or less stable, but with certain disabilities. All patients will receive a 1-hour IV infusion of FGF1 5 days a week for 4 weeks. So it's a pretty long infusion period. Commitment by the patients. We'll put a PICC line into the patients, so we won't have to be sticking them every day. And we'll be measuring safety and effectiveness. We're going to follow the patients out for 1 year. This trial should start in about 3 to 4 months' time. We'll be at centers that have functional MRI, so we can measure blood perfusion in the brain before and then at select times after treatment with FGF1 to look at regional blood flow in those patients. This just shows you an example of blood flow, blood perfusion. Blue is in a woman with dementia. Blue is normal blood flow. Yellow is reduced blood flow, and red is severely reduced blood flow. So in dementia, this is occurring in the cortical regions involved in memory and executive functioning. So we'll be doing similar types of scans on the patients with stroke disabilities. Now, we're very excited about using intranasal delivery, which would be much easier. And proteins such as insulin have been delivered intranasally. They gain access to the brain through the olfactory nerve. We've just completed our first study in rats, and indeed we can get FGF1 into the brain of rats through the intranasal route. And just scanning the literature, I found a group in China. So this is the same exact protein we're using. FGF1 is also called acidic fibroblast growth factor. And they intranasally showed that it induced neurogenesis and angiogenesis in rats after ischemic stroke. So that's, again, very promising in animals. We're going to be trying it, repeating this, and then set up a first-in-human study to see if intranasal FGF1 as any benefit in stroke recovery. So feel free to email me with any questions. Here's my email address. Zicha, Zicha means health, means life in Ukrainian. The head of our company is Ukrainian. She had the only vote on the name of the company, so that's what it is. And we have a website, zgm.care, where you can learn about our work in the heart. We're also using this as a wound healing agent in healing diabetic foot ulcers. So you can look at our other medical indications if you go to that website. So thank you for your attention, and Dr. Salim and I would be happy to answer any questions that you may have.
Thank you, Professor Jacobs. Thank you for this very nice talk. And I think now the future is with the natural drugs, with the natural factors. And I think it's very encouraging way of research. And thank you for all what you are doing in stroke. I think it will benefit all our patients. So I think now the discussion is open, and I think you can see some questions on the screen. I think you can maybe, Professor Magdi Salim, maybe you will start by responding to these questions. Maybe we'll start with one question. I think stroke is a huge problem in developing countries, especially in Africa, with Black ethnicities. And we have a problem of delay of time that patients take to arrive to the hospital. And also the door to needle time is very long. So I think what are the strategies you think for developing countries? I think United States is quite a developed country, but in developing countries, how countries should battle and overgo this obstacle?
Oh, that's a complicated question. So I think there are two issues in developing countries. So number one, getting the patient to the hospital. So that really will require a lot of public education, I guess, about the symptoms of stroke first. That the families need to recognize that when someone has a symptom suggestive of stroke, that they really need to get to the hospital immediately. Then there's the issue of traffic, which I cannot solve.
Yeah.
But then the issue of the structure within the hospital. So I think the way to go about it within the hospital is really what the United States did. That the health ministry will have to come with some guidelines and time targets that these hospitals will have to meet, and there will have to be some quality measures that everyone follows. And it depends really on the structure of the country. If they get any payments from the government or not, the payment should be tied to the performance in these times. This is the only way to actually improve things. Within an institution. If you just leave it to people kind of out of the good of their hearts, I'm going to be running around and doing this within 2 minutes and then within 5 minutes, I think it doesn't work well. So it needs educational campaign, I think, and I think on the administration level, that you have to set targets and reward people that do well.
Thank you very much. So I think we have some other questions. There is one question from Mr. Nangopal from India, I suppose. Can arterial spine labyrinth perfusion replace contrast magnetic resonance perfusion?
That's a very good question. So in theory, yes. I'll have to tell you that our institution many years ago, we tried to actually use ASL instead of the contrast for the perfusion study. But the resolution was not as good. And part of it is related to the movement of the patient too. The arterial spin labeling seems to be a little bit more sensitive to the motion artifact than the gadolinium one. So it didn't really work for us. But I think there is a couple of places in the US that are actually using it. So in theory, yes, you can use it.
Yeah. Second question, how do we define a diffusion flare mismatch in real life practice? Is there a faint flare hyperintensity or small area or flare hyperintensity? Will this be counted as mismatch or no?
Well, so it's mismatch means that so if it's small, but if So you're looking at the diffusion lesion and the flare lesion, right? So if there is a flare lesion, but it is smaller, that means that the infarct is old. And I see the point from the question now, the more I think about it. So he's saying if there is a small flare lesion, then that means that it's old, but it's small. Should we treat or not? I tell you the truth is that the diffusion and the flare mismatch is becoming sort of a little bit irrelevant at this point in time with the introduction of thrombectomy. So the Wakeup Trial started before thrombectomy was in full gear. And now most of the time, if you find someone has a large vessel occlusion, you're going to take them to the angio suite and kind of open this. So you will rely more on the criteria of what I mentioned about the perfusion imaging and the size of the co-infarct and the size of the number.
Okay, there's another question. Is parenchymal hematoma grade 3 hemorrhagic conversion or infarction post-intravenous tenected place in resource poor settings for mechanical thrombectomy that is asymptomatic and detected on repeated CT scan 24 hours showing large infarction after thrombolysis? Will you use platelets or cryoprecipitate?
I think there is no clear guidelines there, to be honest with you. If it's asymptomatic and you're only detecting it a day later, then I think there is some rationale to just wait and see what happens. But if you want to treat it, there are American Heart guidelines which suggest the use of cryoprecipitate, and you titrate it depending on the fibrinogen level. At our institution, we only use platelets if the platelets are low, because the evidence of just giving platelets without low platelet count is a little bit not very strong.
Okay, another question. Do you recommend RTPA after only doing CT scan in resource poor settings?
Within the 3 hours, yes.
Okay. Another question. There was angiogenesis in, I think this is for Professor Jack Jacobs. There was angiogenesis in FGF-derived TRATs, but disordered and hemorrhagic transformation. How does FGF derive normal angiogenesis from the cartoon at the beginning of how FGF works? Please explain how this organization happens, and as in infarcted areas, there is no blood vessels to maintain the scaffolding.
Good question. So FGF1 regenerates tissue. So it actually remodels not only growing blood vessels and growing linked to neurogenesis, but actually can regenerate, remodel tissue. So in the heart, we see remodeling of the heart tissue, healthy heart tissue in those animals. We saw remodeling of their brain tissue. So it's more than just blood vessels and nerves. You actually get activation of enzymes, metalloenzymes, that help remodel the tissue so it becomes non-ischemic. So there's a lot more going on than I showed you.
Yeah, there's another question for you. Your angiogenesis paradigm, I think it looks very interesting. How does it translate to neurogenesis as you use in two concepts seamlessly? Neurogenesis is different and more complex as is angiogenesis. We need a stamp of blood vessel for FGF to work. So how do you comment this nice concept?
Yeah, well, we believe that the two are linked. You can't have neurogenesis without blood perfusion. So we believe the angiogenesis, regrowth of new blood vessels, is linked then to neurogenesis, and mainly through better activation of the neural stem cells. We all have pools of these stem cells that are around that normally can be used to help repair damage in brain tissue that's underperfused. These stem cells are basically just not as active. So we think bringing in blood perfusion to those areas that are ischemic reactivates those stem cells. And so the two really are connected. You can't really have proper neurogenesis without proper angiogenesis or proper blood flow in the brain. And we
Thank
think
you.
this applies to a lot of different diseases. We're seeing in models of Parkinson's disease, we've treated monkeys and we've stimulated more blood flow in the substantia nigra region of the monkeys. We've regenerated dopamine cells in their brains and we've seen improvement in their motor score. So this isn't our concept, but I think a lot of neurologists feel that there are a lot of vascular issues underlying not only stroke, but these neurodegenerative diseases as well.
Thank you. So a question for Professor Magdi. What's the best management of patients who has stroke before and he is diabetic and hypertensive to guard or to prevent from another stroke?
Well, to treat the hypertension and the diabetes, especially hypertension. The hypertension is probably one of the most powerful predisposing factors to stroke. So to prevent another stroke, you really have to address the risk factors. So our guidelines for the blood pressure recommend that your target blood pressure should be less than 140/90 and even lower, the lower the better. And for diabetes, that the hemoglobin A1C should be less than 7.
Yeah. So maybe I can add another question. What are the limit to respect of hypertension in order to protect the brain when it's happening during stroke? Is it 185 millimeter or maybe much less?
So the 180, so it depends. So the 185 systolic blood pressure is what we use if the patient receives thrombolysis. So we try to keep the blood pressure not higher than this to prevent the risk of hemorrhagic transformation. But if someone just has an ischemic stroke, you really want to maintain perfusion to the brain. You don't want to drop the blood pressure. So we let them auto-regulate. And sometimes we tolerate up to 200, 210. So it really, it depends on the treatment and the specific situation for the patient.
Okay. Another question, what do you think about prophylaxis, aspirin or clopidogrel in preventing stroke, Professor Magdi?
So it depends. If we're talking about secondary prevention, yes, of course, there is a value for aspirin and clopidogrel. But if we're talking about primary prevention, we really have little data to support either one of them for preventing stroke.
I think another question for Professor Magdi is Southeast Asia. I think it's a question from India. Is Southeast Asia where there is predominance of intracranial stenosis and thrombosis causing stroke? Did you wish to talk about your slide where you showed LVO M1 versus M2 in the circle scatter diagram to inform in management of intravenous intra-artery thrombectomy TPA is better?
So the trials, most of the thrombectomy trials that I showed had very few patients with M2 occlusion. So most of them were M1. However, I showed you this Hermes meta-analysis from them and suggested in the M2, it worked too, but it was a small number of patients. But the truth is, the stents are getting better and the interventionalists are becoming more comfortable with the procedure. So even at our institution, we're opening a lot of M2s now. So it's not really different than the M1. So if they qualify for thrombolysis, before we go ahead and treat them and then take them to the angio suite. If not, they go to the angio suite and we do the M2s. So it's not a problem for us.
I think another question is Techneplase better than RTPA from what you showed in the 100 points? I think it's mentioned that it's recommended in India. What's your point of view?
Well, I know it's used in India, but I didn't say that it's better. So all I said is that we have evidence that it's not inferior. And in the 100 patients, it was better, but that's a very small study. It's only 100 patients. And that was not the primary outcome. So I would be careful to say we don't have any data to say that it's better than TPA. We have data to say that it's not inferior to TPA.
Yeah, but I think it's simple of use and cheaper maybe.
Maybe you can use that, but I think that there is an ongoing large phase 3 trial to really tell you for sure if it's better or not.
Okay, thank you. We have also another question from our colleague Massar Diagana from Senegal. What about angiogenesis stimulation in EFGF1 in patients with malignancy and stroke? Is there any risk to worsen the malignancy? I think this is for Professor Jacob.
Definitely a risk. We would never give a potent angiogenesis factor to anyone with a malignancy. So they're screened very carefully before they go in the clinical trial. But we know our FGF1 does not initiate cancer. So we look very hard at that in animal studies. In our heart studies, we treated over 100 patients. We looked very carefully at their tumor markers. We never saw an increase. And we excluded anyone with a history of cancer. So yeah, if someone presented with stroke and an active malignancy, we could not treat them.
Thank you. So a question from Professor Selim, from our colleague from Gun from Africa. You had some fascinating details regarding neuronal loss. How is neuronal loss measured? Can this measure be done clinically or only for researcher purposes? Do you think knowing the progression of neural loss influences management decision?
I don't know how to measure it clinically, to be honest with you. I'm going to ask Dr. Jacobs for his help with this. But does neuronal loss affect my decision? So probably not, because that's the one thing that I said we still really need to work on is the location of the stroke. And I think location makes a big difference in terms of the resulting deficits and the outcome as well. And this is something that we have not been very careful about yet. It's not integrated in our mix. And so I don't know if Dr. Jacobs want to say something about how neuronal loss is measured.
Well, we're still in animals, and you saw the slides. We kind of look at brain slices, and then look at motor skill testing. So we infer we're gaining neurons by improvement in function in the animals. So in people, I'm not a physician, so I have to.
Yeah, I think it's a little bit difficult in people. Yeah. I mean, of course, the larger the stroke, you would expect the greater the neuronal loss. And then the more the deficits, the greater the neuronal loss. But it's not like an accurate quantitative assessment.
Yeah. Another question for Professor Jacob. So I'm resuming some other questions, and I'm giving just the opportunity to people to ask one question, not too many questions. So this is for Professor Jacobs. Does FGF play a role in neuroprotective during cerebral fluorisis?
Yeah, this is not our work, but people have shown that FGF1 is neuroprotective in cell culture, and they've studied it in acute stroke, and they find that it can protect the penumbra in an acute stroke model. This is not our work. So it does have neuroprotective properties. The problem, actually a clinical trial was done in acute stroke, and giving bolus injections of FGF1, it's caused hypotension, which, as Dr. Salim mentioned, you don't want to give acute stroke patients, make them hypotensive. And so that trial was actually stopped. And that's why we're looking more at chronic stroke, acute stroke, where we can do slow infusions over a period of time.
Thank you. Question for Professor Salim. How long you keep blood pressure on high end to save penumbra after acute stroke?
So if the patient is not treated with thrombolysis, we usually don't touch the blood pressure for at least 72 hours.
Okay.
So 3 days.
So we have other question from YouTube. So we have a question from our colleague Tanya Colin Martinez from Latin America. Have you make cohort, how you make cohort between mouses with comorbidities and healthies for the use of growth factor 1 for Professor Jacobs?
Okay, I didn't get that question. Comorbidities? They're asking about comorbidities? Or?
Yeah, comorbidities and healthies. Have you make a cohort between mouses with comorbidities and healthies for the use of growth factor 1?
No, we haven't done that. I'm sorry. We haven't.
Thank you.
Made different cohorts, animals with different disabilities, I think is what they're asking about. No, we haven't done that yet.
I think maybe
Another question. Yes, Professor Salim.
No, I was just going to help with the question, I guess. I think the question is, you know,
help me.
No, there's always this debate about animal models. They don't represent the comorbidities that you see.
Yeah.
So I think that's what the question is trying to get into.
So another question from Professor Salim. I think we'll be finishing in a few minutes. So for how long should you continue on aspirin or clopidogrel after stroke?
Also, so not all patients go on the combination of aspirin and clopidogrel, but the ones that do, we do it for 3 weeks. And then after there's just monotherapy. And the reason for this is that after 3 weeks, the risk of hemorrhage starts to go up.
Okay. Another question for Professor Salim. Is there any role of intravenous abciximab in case of acute large vessel occlusion?
Well, I mean, there's a trial going on looking into that. Some of the interventionists, sometimes they use it, but there is no clear kind of trial evidence to suggest that that's what we should be using now. But it is used off-label.
Okay. Another question, post-circulation strokes and cerebral strokes. Should we look at these differently than the anterior cerebral artery and the mild cerebral artery strokes and time windows we discussed? We don't have good clinical markers and trial designs to post-cerebral arteries and basilar occlusion. Comments, please.
Yeah, so there's always the debate that the posterior circulation is more resistant to ischemia. And maybe that after even 24 hours, that you still have the number in a posterior circulation stroke. So we do sometimes with basilar occlusion, just because we know that the outcome is very poor. We actually do go ahead and treat them outside of the 24-hour window if the imaging is favorable. For PCA, we treat the PCA just as MCA and the ACA strokes.
Okay. I think last question, how expensive you expect the angiogenesis therapy would be in future for developing country population, as it's usually out of pocket for patients? For Mr. Jacob.
Yeah, I'm not an economist, but I know our CEO said our medicines will be priced at 25% of whatever the standard of care is in a specific country. So we're not going to price this like the new Biogen drug for Alzheimer's. It's going to be reasonably priced and people will be able to afford it.
Thank you. I have one question for you, Mr. Salim. You said that now we are trying to extend the duration or indication for thrombolysis till 9 hours. So I think, can we still do this if we don't have MRI and perfusion, for example, just with the clinical mild evolution with CT scan?
No. So I think what I made it clear, maybe it was not very clear, that after 6 hours, you really need to have perfusion imaging. So I'm one of the believer that the reason why the trials have good results is that they selected the patients very carefully. If we're just going to start to treat everyone, then the outcome is not going to be good.
Okay. And also, can we give LMWH in case of posterior circulation stroke?
Well, so in general, really heparin, there are very rarely any indication for heparin in a stroke. That's like an old practice where people used heparin a lot in stroke patients. But we don't have anything to suggest that they are needed in the acute setting, except for very few indications. And I don't think it really matters if it's anterior or posterior circulation. So again, this is the old thinking, because the basilar was associated with poor outcomes, so people would automatically anticoagulate these patients. But there's no evidence that this changes the outcome.
So I think these are the main questions, and I think we have other questions, but I think we cannot go in all details because we are running out of time. So thank you very much, Professor Magdi Salim. Thank you very much, Professor Jacob. Thank you, Mr. Shady, for this nice organization. And I think Mr. Shady will give some closing remarks. Thank you also to the Medical Research Center of Marrakesh University of Qadi Iyad and the Marrakesh Medical School. Thanks to all the attendees and all the participants. Mr. Shady, some final comments. Mr. Shady, if you have no more comments, so thank you very much. And yes, Mr. Shady.
So thank you everybody who joined us for this great and successful webinar. Thank you, Professor Magdi Salim and Professor Jack Jacobs for accepting our invitation, and looking forward to seeing you among us for the upcoming webinar next month on the Alzheimer's disease.
Thank you, everyone. Thank you.
Good.
Thank you. Bye-bye.
Pleasure. Thank you. Take care.